The migraine brain is wired different. The migraine person will perceive light differently, sound differently, smell differently. Migraine runs with, now we think, over 60 comorbid conditions. We now know that the number one associated condition with migraine is anxiety. Depression is in there. Asthma, atopic dermatitis, hives, that type of thing. Irritable bowel syndrome. There's a ton of things that run with it. Bipolar has been associated with it. Don't forget that the migraine brain perceives the world differently than the non-migraine brain.
It's just hyper-excitable.
So if you're on a dock and a fairy went, "Brr," it's the migrainer that'll jump.
Yeah.
And everyone else will be like, yeah, that's just a horn. Not everybody drives their migraines with a CGRP pathway. Behind CGRP is another med that's also an alphabet soup. Not CGRP, it's PACAP.
The new kid on the block,
And
right?
that's called PACAP. We think maybe 15% of the world or so drives their migraines with PACAP. They won't respond to CGRP. Personalized medicine, I think it's coming, but we are not there yet.
Where do we stand on the Daxify?
So,
All right, excellent. Okay, we're ready to get started?
yeah,
Let's do it. Okay.
Absolutely.
Hello, everybody. This is Dr. McAllister, Dr. Peter McAllister for the full name. He is a neurologist and a headache specialist. And he basically not only prescribes a lot of the CGRP medications and all the migraine meds that you're on, but he ran a lot of the clinical trials on those medications.
refractory migraine that's difficult to treat, most of them are chronic migraine. We have a few episodic migraines who are high frequency, 12, 14 headaches a month, and they've tried everything. When I see somebody as a specialist in a tertiary care center and they say, "Doc, I've tried everything," I always really want to get down into the granularity and say, well, what does that mean? If that means you were on topiramate 25 milligrams for a week and you didn't like it because your fingers tingled, well, you failed it for a side effect, but you didn't fail it for its efficacy, how well it works, right? I'd want to know if you had Botox, for example. That's approved for chronic migraine. And if you did you have at least 3 cycles? If you had just 1 cycle of Botox, again, as the principal investigator for that trial, I can tell you a lot of people needed 2 or 3 cycles before it started working. On and on. If you were on a CGRP drug, if you're on a Jovi or one of those meds or Qulipta, I'd want to be sure that you're on the right dose for the right amount of time. And then we combine things. There's data to suggest Botox plus a CGRP drug, for example, can be very helpful. But when you do that and you also do one of the neurostimulators, let's say the Nerivio, which is an armband, there's still a group who's failed all that. So now we're into the territory that you asked your question. Ketamine is usually for people who have failed all the standard traditional stuff, or they have side effects to all the different conventional medications and they just don't want to keep trying them because they're up against a wall and nothing seems to work and it all causes side effects. So ketamine is for people who have refractory migraine and have failed multiple things. The group that we think, we have a sense, and we published on this, that may do the best are those who have, like most of us, more than one medical condition, right? So our chronic migraine patients have a success rate with ketamine. But don't forget, a lot of people with chronic migraine have depression, or a lot of people with chronic migraine have had trauma and a post-traumatic stress disorder. So if you have what we call a comorbidity, something that runs with migraine, we find we can often get a 2-for-1 or sometimes a 3-for-1 out of ketamine. So those are the people I'm looking for the ketamine treatment.
Great. I'm sure there's going to be more questions about ketamine, but
it is a hot topic.
It is a hot topic, yes. Well, one question maybe that I have, and also inspired by some of the questions that we had in the community, if somebody were to have good benefit from ketamine, would they necessarily need to have it done again, let's say in 3 months?
Yeah.
Or is it a one-time thing and then that's it?
So, the good thing about having a practice in which I have medical students come through is I have indentured servants that can collect data for me. And they do it, it's good for them too, because they get a research project. And we just had one published with us. And medical students,
what you're saying.
medical students love to publish. So what we did is we followed our ketamine patients, about 600 of them, and we called them with their permission the day after ketamine, the week after, month 3, and month 6. And we had standardized questions and testing, but basically the short of it is, are you still better?
Yeah, I'm just wondering.
So what we found out was that about 2/3 of people, the ketamine will ultimately wear off, and it wears off in 3 to 4 months. It can go as far as 6 months. A small group of people, about a third or a little bit less, seem to have some sort of permanency, or at least out beyond 6 months, where they are reset. We've gotten them from chronic migraine to either no headache, but that's not too common, but we've gotten them to a lower migraine state, so all of a sudden medicines that didn't work better for them.
Yeah.
So the typical patient, the 2/3 patient, gets a good run. Their lives are transformed for the better. And by month 3, 4, 5, 6, it begins to wane. So some of them will come in for a 1-day or 2-day booster. We've got some people who have left our area. I can think of a woman who's now a veterinarian who flies up and does 1 day 4 times a year. And she's been doing that for about 3 years.
Wow.
As long as she does her 4 times a day, she has very few migraines and misses no work.
So it's almost like a loading dose, and then you have a maintenance
Correct.
once every few months.
Correct.
Interesting. Okay. I like to think about ketamine as almost a way to reset the system, right? And to resensitize the receptors. Now, I feel like we have more data when it comes to chronic pain and opioids in terms of resetting the opioid system.
Yes.
Do we have any specific data on resetting, let's say, the CGRP or serotonin receptors when somebody is on, after a ketamine course?
Oh, it's a great question. I don't have any data that I know of about that. What we do know in animal models is if you gave a rat ketamine and then you looked later at its brain, and then you gave another rat a placebo, just the vehicle, right? So they didn't get ketamine. And you looked at their brain. The rat that got the ketamine, actually, when you stain for synapses, those are the nerve connections, there are many more synapses in the rat that got the ketamine. And there are also sprouting of nerve terminals and new dendrites. So the idea that we've come, and this probably applies to humans because it's weird to think about, but we have a lot of genetics similar to rats, some of us more than others. And we call the concept neuroplasticity. The idea is we change the brain for the better. If you're in a chronic pain loop, that gets reinforced. The pain pathway gets reinforced, and the pain track, the other tracks near it kind of wither. And we get workarounds, is how we kind of think about it conceptually, where we get workarounds around this pain pathway so that you don't have that anymore.
I really like that explanation.
Yeah.
That makes sense. Because those patients a lot of times have exhausted let's say, all the CGRP medications, and they're not really working anymore. So going around them and kind of having a collateral or circumventing the circuit, it seems like a good idea.
The other interesting thing, and we're finding this from our research, is this calcitonin gene-related peptide, which we call CGRP. Turns out it's the major but not only bad guy in initiating the migraine cascade. Great. So all we do is we get CGRP blocking drugs, and those are the Quliptas and Ajovis and Vyeptis and all that. But what we've learned is not everybody drives their migraines with the CGRP pathway, right? So behind CGRP is another med that's also an alphabet soup, not CGRP, it's PACAP.
That's the new kid on the block,
And
right?
that's called PACAP. And we think maybe 15% of the world or so drives their migraines with PACAP. They won't respond to CGRP. They'll respond to PACAP. Behind that is another one called PAR2, PAR2. And then there's adrenomedulin and amylin. So, just like we have different hair color and eye color and heights and all that, we probably have different systems that predominantly drive our migraine. Here's what we need. We don't have yet, but we're working on. Is something called a biomarker. Wouldn't it be nice with a blood test, a cheek swab, whatever it is, to say, you're going to respond to a CGRP drug, you're going to respond to a PACAP drug, etc. Personalized medicine. I think it's coming, but we are not there yet.
Yeah, that would be the dream, right? Precision medicine.
Mhm.
Great answer. Thank you. Okay, let's see. Who would like to go next?
Hi, again, thank you so much for this. This is huge.
Sure.
Huge. As far as ketamine goes, is that something that is effective with vestibular migraines? Because I suffer from very severe vestibular migraines,
Yeah.
and I'm having a real hard time with treatment.
Do you also have some pain component, or is it exclusively a dizzy thing?
I have pain as well.
Yeah.
Not I do get migraines with pain, but I'm more frequently I've had a chronic vestibular migraine for almost 6 years,
hmm
and the dizziness is insane. Or
So
the wooziness, I should say, not dizzy, woozy.
yeah,
I'd be better off on a boat.
I have a lot of patients with this. It's not uncommon. It can be quite disabling. What I can tell you is anecdotally, we have had success in our ketamine center with that, but there's very, very little published on it. We think of ketamine conceptually as working for kind of the worst of physical and psychological pain because the brain doesn't really know the difference. And that's why, if you Google it, you can see it can work in depression and severe OCD and post-traumatic stress disorder. We use it in migraine and cluster headaches and all the other really difficult to treat ones. But I have a number of patients in ketamine who have had the worst tinnitus, severe ringing in the ear.
Oh, yeah, it's awful.
Yeah.
It's never quiet in my head.
Ketamine, I've had success with that, and I will publish. We've submitted it. It's not published yet. Here's another one, irritable bowel syndrome, which actually has been renamed to disorders of gut-brain interface to give you a sense of how there's nothing wrong in the gut. You can do a colonoscopy, it's normal. You can biopsy the stomach, it's normal. It's a functional disorder, and I've had success with ketamine there too. My point is, it's not just physical and psychological pain. It can work on other stuff. We just don't have a lot of scientific studies to suggest success with vestibular, but we can go into the logistics of ketamine if you want and the side effect profile. It's generally felt to be safe and well tolerated, so it's something you could at least consider.
Okay, yeah, I have Ehlers-Danlos syndrome and bipolar as well, so I know that it's used in those. So that's
Absolutely.
good to know.
Yep. Migraine
Thank
runs with, now we think, over 60 comorbid conditions. And comorbid is where one condition occurs with migraine at a greater than expected just by chance. So for example, I don't know, toenail fungus and migraine in the same person, that's just chance, okay? But we now know that the number one associated condition with migraine is anxiety. Depression is in there, asthma, atopic dermatitis, hives, that type of thing, irritable bowel syndrome. There's a ton of things that run with it. Bipolar has been associated with it. And we all know about, this burgeoning evidence of hypermobile Ehlers-Danlos, the overlapping circles with chronic pain and with migraine and with dysautonomia. So,
Yeah, the POTS and all that.
Yeah.
As I like to say, migraine has a lot of friends.
yes.
Right? Unfortunately, it's a
I
very
love the combo
popular.
platter.
Yeah, right, pretty much. So a lot of people have those, and it seems to be shared genetics,
Yeah.
right? So it's not so much that, let's say, migraine is driving the depression or the anxiety, or that anxiety is driving the migraine, right? It goes in a very bidirectional way, and it's probably that they have a shared genetics that's kind of driving both, right?
Correct. In fact, Richard Lipton, who's a big migraine researcher at Montefiore in the Bronx, right down the road from us here, showed that it is a bipolar directionality where depression can be a trigger for migraine a trigger for depression, or both can exist without triggering either in the same person. So it can be any way.
Exactly. Yeah, no, great points. Yeah, vestibular migraine is a very challenging subtype of migraine from what I find. I don't know if you find the same or not, but I feel like people who even have a chronic migraine, but that responds to, let's say, the CGRPs or a lot of the other medications, and Botox too, vestibular migraine doesn't seem to obey the same rules.
Well, we just had a first study in which an anti-CGRP drug was proven successful in vestibular migraine.
Which one?
Ajovy.
Okay, nice.
Which is fremanezumab, which is an Israeli product. So we think that these CGRP drugs can turn off migraine, not just the pain of it. We know they help the nausea, the light sensitivity, the sound sensitivity. But to get back to your original comment, it's really hard to treat, but it's also hard to diagnosed with certain things.
Yes. It's underdiagnosed.
There's Mal-de-Barkmont syndrome, which is that feeling like you just got off a boat. There is Meniere's disease. There's other vestibular.
PPPD, I think, is very
Yeah,
commonly.
triple PD, which is sort of the brain's reaction to the world and being overstimulated. And by the way, these can exist together too.
Yeah.
You know?
Yeah.
Don't forget that the migraine brain perceives the world differently than the non-migraine brain. The migraine person will perceive light differently, sound differently, smell differently. They have hyperekplexia. What a great word, right? Hyperekplexia is exaggerated startle. So if you're on a dock and a ferry went, "Bah," it's the migrainer that'll jump.
Yeah.
And everyone else will be like, yeah, that's just a horn. The migraine brain is wired differently.
It's just hyperexcitable, right?
Exactly.
Lower threshold to be.
You know, we all have a dampening ability. In fact, here's another thing you'll think either is interesting or gross. If you're in the operating room and you take the skull bone off and you're looking at the brain,
Yeah.
you know what it's doing? It's pulsing. It's pulsing.
Yep.
Why don't we all have throbbing pain in our head? Because we have a dampening mechanism, right? We dampen it. Migraine sufferers lose the dampening mechanism
Interesting.
because they have hyperexcitable brain.
Yeah.
Yeah.
I can see that.
Yep.
So there was studies on McAllister, I believe, in vestibular migraine, and I think that was up until very recently the only CGRP that was shown to be specifically beneficial in vestibular migraine. We don't have that many studies on vestibular migraine. So you're saying Ajovy now has entered the club too?
Ajovy, it's not a big pharmaceutical sponsored trial.
Right.
This was a group of
Like a smaller
doctors from Italy who enrolled, I forget, 50 patients,
Okay.
etc. So it's a little lower level in the evidence chain,
Fair enough.
but at least we have something demonstrating that
No, but that's good.
likely
We
is
need,
effective.
yeah, I mean, we need a lot of evidence for CGRPs and Botox too, right? I think there's very few and small studies on Botox and vestibular migraine. And it's a question that comes up a lot, right? Is Botox going to help me or not for VM? Especially that vestibular migraine seems to also be different subtypes within it. You have the more kind of headache predominant subtype, but then you have the more dizziness predominant subtype.
Right.
And they seem to behave differently depending on the medication and the pathways.
Yeah.
Excellent. All right, let's see. Next question. Whoever would like to unmute and just kind of go ahead, because I'm seeing a lot of hands, which is great.
For somebody that lived quite a distance, would it be something that a lozenge for ketamine? I've heard about those. Is that something that would be used? Or would it strictly be something where you would need to go to a clinic to have it administered? I'm just curious, as someone who has started ketamine treatments in a clinic, what the best course would be, because I haven't been in a inpatient setting. I haven't found a provider to do that.
Yeah, I mean, it's a great question. So in our practice, we do use lozenges and we use a compounded nasal spray as well. My feeling, and again, this is borne out a little bit with some of those animal models I told you, is that you probably have to get that induction of high dose intravenous to start. And that, my feeling looking at the literature and my experience with patients is such that I don't believe that the nasal and the lozenge ketamine produce that neuroplasticity to any extent. What they can do is if you have psychological comorbidities, you can do a lozenge and do ketamine-assisted psychotherapy. It's incredibly effective. It opens the brain up a lot more than trying to do, for example, trauma psychotherapy. So we have trauma therapists who we use that type of stuff. And the other group is if you've responded well to our ketamine. Let's say you've gone from 27 bad migraine days a month and you're down to 6 or so. Okay, good. And now maybe Nurtec or something else is working where it wasn't working before. Great. As I said earlier, eventually there is in most people some degree of wear off. So before you have to come into us, you can use a nasal spray of ketamine, which, by the way, compared to lozenge, the nasal spray has a little higher blood level, so I tend to use a little more of that. That can get you back righted for a bit. And basically, it can keep you out of my office a little longer. But I think ultimately, most of our patients do need the big IV booster.
So it's like the IV is superior basically to any other and more bioavailable than the other forms.
Yeah.
And then second to that would be the intranasal.
Correct.
And then what would be the third line? If you
Would
were
be
to
the
rank them
troche or the lozenge.
by wrap.
Yeah.
Okay, got it.
It's,
Because there's so many forms,
Yeah.
right?
The thing you can't do is swallow it because it's almost got no bioavailability
Right.
in the stomach. So if you dissolve it, you can absorb it in the buccal mucosa. Nasal spray done right, because you have to spray forcefully and get it up there. You're probably laying a little bit of it on the SPG as well, right? Not a bad idea.
Yeah.
But yes, the IV gives you 100% bioavailability in 30 minutes.
Yeah.
So it's really got a very high level.
Yeah, and I think that's part of the reason why you hear sometimes people talk negatively about ketamine and they say like, "Oh, I've tried it, it didn't work." But it could be that basically they tried the oral version or they tried some other non-IV version, right?
Yeah.
Because the IV infusion course for 4 days or 5 days, that's going to be the one with the highest
Yeah,
benefit.
and each of those days we go up on the dose. We want to make sure you're tolerating it, etc. And I have found that some people do not get to a high enough dose.
Right.
I had a woman who got ketamine in London. She was studying over there at the London School of Economics.
Yeah.
And I said, really refractory migraine. And I said, well, have you ever heard of ketamine? She said, I did it. And I said, how was it? She said, it didn't work. And I said, well, what was it like?
Yeah.
And she said, I hardly noticed the IV. I was still on my phone the whole time. So I said to her, of course it didn't work, right? It is a gentle floating out in the cosmos, really. You have to have a sufficient enough dose.
I mean, the same applies to any medication, right? Like
Yeah.
if somebody tried 10 milligrams of Qulipta and they didn't have any benefit, that doesn't
Correct.
mean it failed.
Right.
They should have been on the 60.
If you
maybe, right?
sprain
So-
your ankle and you take a quarter of a Motrin rather
There
than
you
3
go.
or 4 of them, same
Exactly.
idea.
It's dose dependent.
Correct.
Excellent. Great question. I'm going to take a question from some of the people who submitted questions before and they couldn't make it for the live meeting. So one question was, several people actually asked this question about the NDPH.
Yeah.
Right. So that is a difficult diagnosis to make, but also a very difficult condition to treat.
Correct.
Now, beside the usual treatments that we borrow from migraine, for the ones who have more of a migraine phenotype, right? If somebody has a very refractory NDPH and they are not responding to the CGRPs or Botox or the usual treatments, and let's say they've already tried ketamine as well, what else do we have in our toolbox that we can offer these patients?
Yeah, so new daily persistent headache, right? People can say, I know it was August 18th, 2018, and it started like that. It's probably a number of things, right? We have evidence to suggest there's some maybe viral component in some people.
Yeah.
Some people, it's rapid chronification over 24 to 48 hours of migraine, right? Some people, it's a pressure thing. So this audience is pretty sophisticated. You probably know that if the pressure in your spinal fluid gets too low, you get headache, and if it gets too high, you get headache. Well, we think some NDPH is actually probably misdiagnosed pressure headaches.
Interesting.
Right.
So like IIH spectrum kind of thing?
And if I get a sense of that, I don't know if your audience knows this, but the cool new thing we are using for idiopathic intracranial hypertension, and maybe some of these NDPHs mislabeled, is the GLP-1 drugs.
Yeah.
So Zepbound has become my go-to for cases in which I do a spinal tap in my office and the spinal fluid pressure jumps out of my tube.
Yeah.
I say, we got to lower that. There is a medicine called acetazolamide that works to lower pressure, but it's got a bunch of side effects. The GLP-1s, well, they're not without side effects. You know, some people get diarrhea, some people get constipation, etc., but they're generally well tolerated. And boy, do they do a lot of neuroinflammation decreasing. They decrease the amount of CSF fluid that's produced.
Even CGRP itself goes down from the studies. Right?
So we are using those drugs not just in NDPH, but across the board in our refractory patients more and more.
I mean, there's also emerging data in migraine itself, even irrespective of IIH and pressure and kind of.
So there was
weight
an
loss.
Italian study done a year and a half ago, and they showed that the average group, which had about 22 monthly migraine days, dropped down by 50% or more on, and that actually, mind you, was a very weak GLP-1.
Yeah.
So we think that,
The raglutide, right?
Yeah,
It was a small
Boy,
study.
you know your stuff.
Yeah,
It
but that was a small study, unfortunately, right?
so that same group, because I met with them when I was lecturing in London a month and a half ago, they are in the middle of a much larger double-blind placebo-controlled
Nice,
study.
good, finally.
Unfortunately, they're still using the same weak GLP-1.
Fair enough.
I would use a
At least they're
dual.
not doing peptides or something.
Exactly.
That's good.
Exactly.
No, but that's, yeah, I mean, that's very promising. In IIH, I think we have the most evidence for GLP-1s, right? And seems to be even independent of the actual amount of weight loss.
So yes, your host here really knows his stuff. One of the cool things that we found was that, you would think, okay, you lose a lot of weight, that brings your pressure in your brain down. But no, the migraine reduction was independent of how much weight these people lost. So it was probably, well, we know that the GLP-1s limit the amount of cerebrospinal fluid produced.
Yeah.
And they also have a neuroinflammatory response.
Very fascinating stuff.
Yeah.
I made a video on this at some point on TikTok, but it was suppressed because apparently it violates body image or some kind of mental health thing. So you may have missed it. But anyway, here we don't have to worry about this on these platforms, and YouTube is usually fine with that too. So NDPH, one thing I find interesting, and correct me if I'm wrong, is basically that there's a lot of misdiagnosis that happens. Right, I think that a lot of times people might label it as NDPH just because they don't really know exactly what it is. But then when you get down to the actual details and the bottom line of what may have happened years ago, it turns out to be either IIH or cervicogenic headache or undiagnosed migraine. Do you believe that it's actually its own entity, or do you think that this is just kind of a grab bag of random stuff that people didn't diagnose properly?
I think that it probably is to some extent its own entity, but there's so much of that peripheral stuff you just mentioned. There probably is, I would think, a post-viral, possibly autoimmune, rapidly progressive, and very difficult to treat headache. The World's Authority, we had him at our conference in Connecticut last year, which we host in Greenwich. And he just layers on mostly migraine meds, but he does 3, 4, 5 combinations, and each of those he thinks decreases it by like 5%. And all you want to do is get them some better.
Some quality of life.
And you have to just, this acceptance and commitment thing to say, you didn't ask for this condition, you don't deserve this condition. I don't know that we're going to make you pain-free, but I want to make you, in aggregate, 30, 40% better.
100%.
So you set these realistic goals, but it's a tough case. I just had a case, I must tell you very quickly, because we did the procedure last week. A guy came from North Carolina. He heard about us somehow, and he told us a story about NDPH. It started one day, etc. And it actually started not long after he had lumbar surgery. And no one really made the connection there. And the only halfway smart thing I asked him is what makes the headache worse? Coughing, sneezing made it worse. And I said, okay, maybe he's got the opposite of high pressure. Maybe he's got low pressure because someone messed around in his spine, and it was not that long after. In fact, he may have had an okay spine procedure with a little bit of a rent, but then coughed, sneezed, fell down the stairs, whatever it was, weeks later, right? And now he's got a leak. So we did a spinal MRI, and there's a certain fancy settings you've got to get to show a leak, but it showed a leak at L4-5.
So he had like a hygroma outside?
Yeah. But it did a blood patch in the office. The guy's headache went away. He's had it for 7 years. So that was a good case.
Those are also very underdiagnosed, unfortunately. They go for several years before an actual diagnosis, and sometimes more than one blood patch.
It is fascinating when you find it, particularly high, very fast leaks. We can find those pretty quickly. But these really slow leaks around synovial cysts or something like that, I mean, there are people who've gone 20 years thinking it's refractory migraine, chronic tension type headache, and you can fix it.
No, that's great. Nice case. Okay, let's see. Who would like to go next?
One of the questions I had was whether there's a set of folks who, in your collective experience, are not appropriate candidates for ketamine. Are there people who should, look elsewhere?
So it's a good question, and I would tell you that years ago, there seemed to be an idea that there was a group that was not very appropriate for it. Those who had significant pre-existing psychiatric disorders were felt not to be good candidates. those people taking the seizure and mood medicine lamotrigine because it worked on a similar receptor like the glutamate were felt not to be. Even there was a little tiny, case review that perhaps people with bipolar were not good candidates. I will say that in our experience, we now have nearly 2,000 people through our ketamine program. None of that is true. So if someone tells you you're not a candidate, question them. I think you should question any doctor and what he or she tells you. Question them. I think that, so what ketamine derived, which sounds a little scary, ketamine derived from angel dust initially. Back in the 1950s, phencyclidine was produced by Park Davis, but it was a really bad trip and it had a lot of blood pressure changes, etc. So they added chemically a ketone and an amine. The word ketamine comes from what they added, ketone and amine. And they had what they developed was a very gentle product that doesn't drop your blood pressure, doesn't drop your respiration. So it is a really safe medication. The caveat is when used properly. Everyone knows about the poor Friends actor who took too much ketamine. And I know some inside information about that, and I will just leave it at this. Ketamine was the least of the drugs in his system.
Right.
But when used properly, it's a remarkably safe med. The number one side effect of ketamine when you do the IV is some nausea. And if you are very, very likely to be a nauseous or puker type of person, maybe that wouldn't be right for you, but I don't know that I would not do it. I can think of literally 2 or 3 patients who just threw up despite our giving them nausea meds. And they said, I'm done, I can't do this. But it's extraordinarily rare.
Yeah,
So
the majority would tolerate it.
just remember that, there's no free lunch and there's no perfect medication. What we have is a very good medication, which has the sweet spot between it works in a lot of people, but not everybody. It's incredibly safe, and it's for most people well tolerated. So I give it a solid B+. It's not an A+ medicine.
A follow-up question on that came up at some point in the community as well. If somebody has a history of psychosis of some sort, or even a family history of schizophrenia,
Yes.
would that be in any way a relative contraindication?
So my feeling is no.
Okay.
When I look at the other drugs, very high potency THC, marijuana, high dose psilocybin, I get very nervous in those people. If you have a significant pre-existing psychiatric history or a strong family history of that, this could get you into a dissociative paranoid state. I have not seen that in ketamine.
Okay.
Again, I would have the conversation with someone if they give me that, and I would say, look, it's not zero.
Yeah.
I had one kid who had, he was in his 20s, he was a Brown University student, and he had significant dissociative state after ketamine. And he felt the ketamine did it. And I had him go back and see a psychiatrist at Brown who's really well known. And after talking to the kid for a long time said, no, it's just his anxiety. It wasn't the ketamine. It's just he got very anxious. He agreed to do another ketamine once we got his anxiety down a bit, and he wound up doing great.
Yeah,
so
nice. Yeah, it seems to be overall pretty safe. But obviously depends on the person, so always talk to your doctor and have the conversation about risk and benefit. To kind of change gears for a little bit, an important question that came up a lot, and I would be interested in seeing what you think about this. When it comes to the transition from episodic to chronic migraine, which is a very unfortunate transition for a lot of people,
Sure.
right? Beside the very well-known effect of medication overuse as being a major kind of risk factor for that, what else promotes that transition?
Yeah, I mean, it's a great question.
And how do you go back?
There is a revolving door to some extent. There is a group of people who go from episodic to chronic migraine. But the good news is there's a group that goes from chronic migraine and reverts back to episodic. What are the risk factors for chronic migraine? Here's one that I think all doctors should know about. Having non-optimized acute care. So what I mean is, and it doesn't matter if you respond to a triptan, a GPAN like a Nurtec or whatever it is, If the medicine works fast, efficiently, and restores your functionality, say within 2 hours, that's optimized. If you don't have optimized care, again, Richard Lipton from Montefiore showed us that those people are much more likely to have more and more headaches and evolve into a chronic migraine state. You can also look at risk factors. So what are the risk factors for going into a chronic migraine state? Well, sadly, one of them is being a woman. So women get more migraines. Women in general have more pain than men. And women tend to chronify more than men do. Another one is having significant non-treated depression. The other one is having a history of trauma, and post-traumatic stress disorder
Makes
is
sense.
also a risk factor.
Yeah.
Obesity is a risk factor for chronification. Again, that's where I think the GLP-1s come in. I think neurologists should be very up on the GLP-1s and be prescribing them for a lot of their patients. Sleep apnea is a risk factor for chronification. So, we have to optimize the patient's sleep. I think we have our volume up a little here. So here?
Let's see. No, it's already
Okay.
Try now.
All right. Is that better? Yeah. Okay, good. So those are just a handful of them. Having a concussion or multiple head traumas, another risk factor for chronification. So there are some things you have control of. Oh, and age as we get older. You can't control age.
How about hormones?
Yes, exactly. The variable period of the perimenstrual period can be a risk factor for chronification.
How about perimenopause? Would that be a risk factor?
Oh, yeah. Perimenopause, again, is just a physical and psychological stressor that can last, as the women on this group know, for months or years, and it can be really hard. Stress in the way you react to stress can be a risk factor for chronification. So those are the big ones, some of which are modifiable, some of which are not.
Yeah. No, excellent points. How do you go back?
How do you go back? You find someone who you trust to lead you on that pathway back. You make sure the diagnosis is migraine, and I say that it should be obvious, but a small percentage of my people, and they say nothing works, and when nothing works, I say, well, let's examine whether you have migraine in the first
100%,
place.
Yeah.
And sometimes we find something else, and that's treated differently. So the way back involves lifestyle and psychological modification, optimizing preventive care, usually combination therapy, finding optimized acute care. Unless you're in an everyday headache, then it doesn't do you any good. We can't discount, in this age where we have really good, safe, tolerable meds like the anti-CGRP drugs, we can't forget about depression and sleep and diet and weight and hydration. And I think we've got such success with these drugs, some of us have forgotten about that a little bit.
The basics, yeah.
And sometimes the pathway back is a trainer. And sometimes the pathway, so everyone's pathway back is a little bit different. Sometimes it's, figuring out, if you know the book, The Body Keeps the Score, realizing that you're holding stuff in your brain and it's coming out either in your body or as migraine, and getting the proper treatment with trauma therapy. And that's another place ketamine can fit in. So there are multiple pathways back, but it involves a shared relationship between an active, motivated patient and finding somebody that he or she trusts.
Yeah, great points. Excellent. Okay, let's see. Who would like to go next? We have a few more minutes.
So I have so many questions because there was just so much good stuff in that. I don't know where to start, but I'll choose a couple. In terms of talking about this kind of transition from episodic to chronic and back again, which we all hope that we can get back from chronic back to episodic. If we're talking about NDPH, is that kind of transition, is that possible with that, or is that a different kind of entity?
Yeah, if it's truly that group that I think is the real legit NDPH. Unfortunately, that is a very difficult to treat condition, and it does not tend to wander back into episodic. I mean, in other words, there is no, in my opinion, episodic NDPH. You either have it or you don't. We do know that there is a spontaneous remission rate often within the first year to 18 months, where just like they say it started on September 8th, some people say that it ended on April 4th 2 years later. So it can turn off. But in my mind, and tell me if you agree, if I really feel it's NDPH and it's not just a really bad, rapidly chronified migraine, it's not a pressure, high or low pressure phenomena, etc., I think I just want to work with them to get them some better. They'll still have daily headache, but as many of you know, on a scale of 10, a 7, 8, 9 headache is fully disabling. If I get you down to a 4, that's not a walk in the park, but boy, is your life better with a 4 than it is with an 8, isn't it?
Yeah.
So that's what I'm going for with my NDPH.
Yeah, no, great point. I agree. I think that ultimately it's about adjusting expectations too, right? Because achieving a complete remission is somewhat unlikely with both chronic migraine and refractory migraine and NDPH, but ultimately having a realistic goal of maybe 50% reduction, right, and function improvement is ultimately much better. I think you had another question, I believe, or not?
Yeah, so it was what we kind of started with at the beginning of the session. It was about biomarkers. So the potential to have a biomarker for migraine would be awesome. In terms of migraine, like it presents in so many different ways, and there's so many kind of different treatment modalities. I was just wondering, like at the moment, is the most like meaningful way of determining someone's individual driver of that migraine, is that just their response to treatment, or do we have a way to determine that at the moment?
No, you're absolutely right. It is the holy grail. We haven't achieved it yet. We are still actively looking for it. The problem is, I'm sure you're familiar with many diseases that are a single gene mutation and you have it, so cystic fibrosis, Huntington's disease, that type of stuff. That's easier. Migraine is polygenetic, and there are clusters of genes, and it's not just one gene. So it does make it harder to establish sort of a, looking at a whole gene sequencing. And then identifying a biomarker is difficult because we know that there are different drivers, different peptides, right? So it may be a combination of markers that'll be available commercially at some point. And we're working on that a little bit, and then to find the suitable fluid. For example, you would think a blood test would be best. Actually, CGRP, which by itself will not be the biomarker, but it's just to give you an example, is much more concentrated in tears than it is in the blood. So, you can do a little tear test. But I think there'll probably be a number of biomarkers and maybe even some non-specific brain stuff, neurofilament light chain, for example. But to get back to your original statement, you're absolutely right. You can give someone an anti-CGRP drug, and if they do brilliantly, you can assume that their driver is CGRP. It's really as simple as that right now.
Yeah, no,
it's
great
just
question.
A lot of trial and error to get there at the moment, isn't there?
Yeah, I know it.
And it's fascinating when you see the responders, let's say, to Qulipta versus Nurtec, right? And, there's like no way to predict, right?
Yeah.
It's just trial and error.
These drugs are more similar than dissimilar, and yet some people are like, this one was night and day, and this one didn't touch me.
Exactly.
But, we have the same thing with the SSRI antidepressants. Fluoxetine and sertraline are much more similar than dissimilar.
Right.
Why does someone hate one and love the other? Because we're all wired a little bit differently, and we all metabolize them differently.
Exactly. Except I think in psychiatry, they use this a little bit more than we do in migraine with, saliva kind of testing and stuff like that.
Yep. So there is there's a number of different companies where they can look at how your liver metabolizes the drug. And it's first of all, not exact science,
right?
But it gives you a roadmap, and I think it's not a bad idea. I use it more to predict who's more likely to have side effects versus efficacy.
100%.
If somebody has a system that does not metabolize a drug, it's going to build up, and they're going to get much more side effects. So those are helpful.
It's a step in the right direction for sure. One question that came up a lot that I know a lot of you have as well is how do you treat the sensitivity to light, what we call photophobia, which for some people is more disabling than the head pain, right,
Yeah.
or the other symptoms. And beside the usual things like the FL41 glasses and things of that sort, do you have any anecdotal evidence based on your many patients over the years of them benefiting, let's say, from, I don't know, Diamox, lamotrigine, something that's off-label?
Yeah, so just the photophobia, you treat the migraine properly, and if you're lucky, you will reduce photophobia, phonophobia,
The whole thing.
smell sensitivity, etc., but not always.
Mm-hmm.
And there, and again, just to your point, and I'll segue for a second, we used to think years ago that every migraine patient was most bothered by the pain.
Mm.
We know that's not true now. In fact, sometimes the pain's almost an afterthought.
Yeah.
It's the cognitive stuff. It's the irritability. There's so many things. What we've learned from our clinical trials is, and I don't know how many of your audience would know this, but you have an attack of migraine. Let's say a few days or a week later, you have another attack of migraine. Well, the period in the middle there when you don't have a migraine is called the interictal period between the migraine. What we now know is that's incredibly bothersome. And you could say, why? They don't have any pain there. Well, they're so worried about the next migraine coming and what they're going to miss, and they're not going to pick up their kid at, flute lesson, whatever it is, that really weighs on them.
Yeah,
and
totally.
Some studies show that the interictal period is actually worse. But to get back to photophobia, I think you treat the migraine and you hope that goes down. There is some variance of that. You may have heard of something called persistent visual snow or persistent aura. So I think the thing you were alluding to, because you mentioned lamotrigine. Lamotrigine is an anti-seizure drug that works on glutamate, and it seems that it probably doesn't work that well on the pain component of migraine, but it can be used for other things. And we mentioned vestibular earlier, but I've had some success with lamotrigine with persistent visual stuff, persistent snow, that type of thing.
Yeah. Magnesium also has maybe some evidence in this kind of thing, and aura too. But yeah, unfortunately, I find those harder to treat than the pain.
Yeah.
So the kind of more less quantifiable symptoms, both the photophobia and the dizziness, I find those they're more disabling for patients and also harder to treat.
And this is going to sound rather cold and callous, and I don't mean to sound like that. But I think if you had significant light sensitivity, the first thing you'd want to do is put on the darkest pair of glasses you could find. And I think there's some literature to suggest you're doing yourself a disservice.
Adaptation.
You should wear them now and then, and when it's very bright and things are moving, of course, take care of yourself. But you need to have time where you're experiencing that to drive it down a little bit, right? And we know that's true in concussion. We think that might be true in migraine.
Yeah, I mean, that's a property of the nervous system and adaptation in general, is that you don't want to be wearing your sunglasses indoor, right, all the time. Otherwise, it's just going to become counterproductive, unfortunately. Great points. Excellent. Okay, we have 7 more minutes or so. So who would like to go next? I'm sure you guys have additional interesting questions. Go ahead.
Hi, Dr. McAllister, Dr. Sater.
Hey.
I'm just curious regarding what you call the cascade. Is the cascade different for every migraine? And the reason why I ask is my experience with Ajovy is 1 month, it's a rock star. The next month, not so good. So am I just an N of 1, or is this typical? I'm just curious.
Yeah, so again, there is no perfect medication, and what you describe, you are not alone. And I don't have an answer for you, except that, all of our lives are up and down in terms of sleep and stress and travel across time zones and the foods we're eating and all that. And I do wonder if one has a more stressful month, does that overwhelm the positive effect of the Ajovy? So it could be something as simple as that. Many of my patients do describe discretely different migraines, and they may have their own cascade or pathophysiology. So there may be something to that. I think that's less well proved.
I think a lot of it is really about threshold, both in terms of the triggers, but also in terms of the protection a medication is going to offer.
Correct.
Right? That's the way I'd like to think about it, is that if you have essentially negatives and positives, right? So you have on one side all the CGRPs, Botox, all the things that are protecting your brain. And then you also have all the triggers which are going to change from month to month, right? Because of the barometric pressure changes, because of hormones, because of the travel, sleep, stress, all that kind of stuff, right? And so even though you might have the same protection, let's say on a given month from the Ajovy, presumably, right? Although that can probably change a little bit too. But let's assume it's the same protection, but your threshold is going to be altered by how many triggers are present in that month. And so on a given month, even if you have the same amount of protection, you might be still crossing the threshold and going into a full-blown migraine attack. That's how I like to think about it, because there's so much variability, right?
Not only do I agree with you, but I've got patients who know when their migraines are likely to be worse.
Yeah.
I give them more anti-CGRP
to
in
protect
those
them more.
vulnerable times.
Yeah.
The brain of a migraine, well, all of us, but again, you guys feel the world more than we do. Not only is there a circadian rhythmicity, but the brain also perceives a circa annual, so there are people who say spring and fall is my vulnerable time,
Yeah.
or during the holidays or whatever it is, and I make adjustments. Many of the listeners probably know about the Migraine World Forum, and they ask so-called experts to come on, and they actually assign the topics to you. And one of my topics one year was what to do when CGRP drugs fail. And I had, I think, a lot of reasonable ideas, but one idea is use more CGRP drugs.
Yeah.
And I'll tell your folks that the FDA in Washington is most concerned when they approve a drug, not with how well it works, but how safe it is, which is a good thing. But they are very, very biased towards safety, and therefore they will use the lowest dose that worked. Okay, which is fine, but isn't life a broad bell-shaped curve? And there are some people who probably need less than the dose approved, but there's clearly a group that needs more. Now, with some of the older migraine drugs, if you tripled or quadrupled the dose, what would happen? You're really sick, you're toxic, it could kill you. What we know about the CGRP drugs, because I've studied them as a researcher, is they are extraordinarily safe. For example, Nurtec, rimegepant. We studied that drug. Now 75 milligrams is the dose. We studied it not at 75 milligrams, but at 1,500 milligrams. There was no more side effects.
That's crazy.
Right.
Every other day dosing or daily dosing?
So the 1,500 was a one-off thing.
Got it.
But then we did daily of 600 milligram for a week and didn't see any side effects. Wow. My point is, and we can somehow magically put insurance and cost aside for a second, which is a big problem, but some people need more than the approved dose.
Yeah.
And some doctors get very nervous about that. I, as a researcher, having studied it, know that that's not true. I had a woman at Yale, a colleague, and she did not respond to Emgality. And she said, well, my husband's a scientist. He says I can do this twice a month. And I said, I know you can. It's safe. I've studied it higher. She did, and her migraines went down 50%.
Yeah.
Well, she came back and said, my husband says I could do this 3 times a month, every 10 days. And I said, well, you'll have a hard time getting it.
Right.
But if you can get your hands on some samples and the one that you get monthly from your insurance, there's no safety issue. Go for it.
Yeah.
Her migraines all but disappeared.
Yeah.
And she never would have known that had she not tried a higher dose.
Was that Emgality essentially, or a different one?
Emgality.
That's Emgality. So
So-
like cluster dosing, or
So she went to 360.
so a little bit higher than cluster?
Yes, a little higher than
monthly.
cluster.
Okay.
And I will also tell you that we are working on a trial of Vyepti, which is the intravenous CGRP many of you guys are familiar with. It comes in 100, but we know that 300, which is also approved, seems to work a bit better. But we have evidence in early studies that 600 works better.
Okay.
So we are studying 600 milligrams.
Nice.
And we think we're going to knock out a lot of migraines.
And that's the thing, right? It's a matter of safety and the fact that in general, most of these are going to be safe,
Right.
right? So you have a lot of margin to go up and potentially have more benefit. I think an interesting thing that will be maybe for the future to determine is how do we identify without the clinical status which patients need a higher dose or
Yeah,
not,
exactly.
right? With the Qulipta, obviously we dose it renally for some patients, but I also have patients who benefit and have pretty much like 0 or 1 headache a month with the 10 milligram. And even though they have a normal GFR, normal kidney function, right? Even with the low dose, when others need the 60. Same with the side effects. Some of them will get constipated on the 30 or the 10, others will not, right? So there's a lot of confounds that go into it.
I'll say two things. One, I want to remind the audience that everything I said about going high on the dose applies to the GPANT drugs and the CGRP drugs. Don't triple or do tenfold of your amitriptyline. It would be
Or
really
propranolol
bad.
or something.
Or
Yeah.
propranolol. All the old drugs that does not apply to. Okay, so anti-CGRP drugs have this wonderful safety built in.
Yeah.
So I think that's really important to emphasize. I don't want anyone to hurt themselves.
I mean, same with Botox. You don't want to overdose on Botox, to the
Yeah,
same extent.
yeah, yeah,
You
you
get
know,
a droopy eyelid or something,
Again, I was a principal investigator on the preempt trial, which was 2007 to 9, and then it came out in 2010 as approved.
Yeah.
By the way, the audience may know that a cousin of Botox just had a positive trial for episodic migraine.
The Dysport, right? Yeah.
Dysport, which is the French product, which is abobotulinum toxin A, is the only other neurotoxin beside Botox. Not only did it hit in the trial because we did it in chronic migraine, but it's the first and only that is going to be approved, we think, for episodic migraine.
Which
so
would be a game changer.
exciting,
Yeah.
very exciting stuff. So.
Yeah, and the thing is, with the regular Botox that we use for migraine, the reason why it's not FDA approved for episodic migraine is not that it's somehow toxic for episodic migraine. It's just that it didn't reach significance for benefit to justify cost.
The problem is, if any of you know about the placebo effect, reasonable brains want to get better, and there's a placebo. Now, there's a placebo effect of a pill, but it's higher with a shot, it's higher with an IV. And if you stick 31 needles in someone's head, it's got a huge placebo effect. So even in Botox's episodic trial, which failed, the drug did quite well in reducing headaches, but the people that got the fake stuff did almost as well.
Exactly.
And that's why it didn't. So this is the first one in which the real effect was greater statistically than the placebo effect.
Where do we stand on the Daxxify?
So Daxxify is a drug that I've studied a lot, and we did a proof of concept study in migraine that we presented in Lisbon at the European Headache Federation. The difference between this new medicine, Daxxify, and Botox is it lasts about twice as long. So instead of going 4 times a year, and those of you who have Botox know it generally wears off in week 9 or 10 anyway. It doesn't last the full 12 weeks. This Daxxify will last on average 21 weeks. It's not approved yet for migraine.
Just dystonia for now, right?
Yeah, cervical dystonia, and we're studying in spasticity. But we hope, the problem is the company, which was a great company, got bought by a not so good company. And they've kind of backed away from therapeutic uses. They want to make their money on like cosmetics. And we're now talking them back into doing the right thing. So we think there'll be a migraine study.
That would be a game changer. A lot of people complain. I mean, that's the number one complaint when people get
the
Botox
wear
for migraine.
Yeah.
It's just it wears off too early, right? But it works really well. People love it. It's a great adjuvant and very synergistic with the CGRPs, as a lot of you already know. So being able to have that long. Do you ever use zinc based on the small number of studies that potentially it can prolong duration of benefit?
I've seen it. I know the literature, and I don't buy it.
Why not? Why not?
I think it's a very simplistic, and I don't think you're getting that.
It's too good to be true. Agree. I mean, it is a cofactor of the, so
correct. It is a zinc-dependent endopeptidase.
Exactly.
If you want to get down to the
mechanistically, it makes sense.
Yeah.
But I agree. I don't know. I mean, it's small studies, but
it's intriguing.
Hopefully, the Daxxify at some point will be approved for migraine.
Correct.
Great, excellent. All right, I think it's already 5:04. Excellent conversation.
Yeah,
hopefully
this
we
was
can
fun.
do this again for part 2. I'm sure a lot of people have other questions.
Come back.
All right.
Come back, right? Yeah, exactly. I know.
Thank you all for listening and putting up with me.
We all learned a lot, and I learned a lot too. What's that word again? I feel like I should make a reel on it. The word you mentioned before about the startle response.
Hyperekplexia.
Yes, I'm not gonna spell it, but I'm gonna try to make a video on it. I think that'll be a nice one.
Yep.
Excellent. Thanks
All
again, Peter, and everybody. I'll try to post the recording as well, and then submit any additional questions to make sure we can have Dr. McAllister come back. Okay. Take care.
Thank you so much.
Take care, everyone.
Bye.
Thank you.
All right. Bye-bye.
Thank you.
All right.
Thank you.